Good morning, everybody. Welcome to Pediatric Grand Rounds. I'm going to turn things over to Dr. Evans to introduce our speaker and our lectureship for today. Thank you.
All right, so welcome everyone, and thank you for those who are here in the audience and those joining online. So today we are presenting the Dr. Robert W. Deisher sponsored Grand Rounds. And to tell you a little bit about Dr. Deisher, he was an innovator and passionate clinician who was dedicated to helping troubled teens, including those who were homeless, runaways, alienated, neglected, involved in sexual exploitation or trafficking, and incarcerated. Dr. Deisher was raised in rural Illinois in a town of 60 people where he attended a one-room schoolhouse. He originally intended to become a teacher, but decided to pursue medicine during World War II. He trained in St. Louis, where he met his wife, who was also a pediatrician. After serving in the Korean War, he joined the UW faculty in 1949. His list of accomplishments is very broad. In the 1950s, concerned that pediatric residents were receiving most of their training in hospitals, he obtained a grant to establish a clinic for well child care involving medicine, nursing, social work, and dentistry. In the late 1960s, he was instrumental in creating what is now known as the UW Center on Human Development and Disability for Children with Developmental Delay, and proposed a school because at that time, no children with an IQ under 70 were allowed to attend public school. In 1973, he started the Pioneer Square Youth Clinic to provide free medical services to homeless teens and young adults. He also sought private and government support for social services for youth who identified as LGBTQ+, and opened one of the first counseling centers for sexual minority youth in Seattle. At the age of 75, Dr. Deisher created programs for youth who were homeless and pregnant. He secured a grant for a nurse and social worker to do street outreach and assist the youth in finding healthcare, housing, nutrition, and social services. He was also an impassioned advocate working for the Children's Bureau at the state level, as well as a committed mentor and teacher who influenced generations that followed him. So we have invited an amazing guest who really is also showing compassion and dedication to youth. Dr. Melanie Nadeau, AKA Dr. Mel, is an enrolled citizen at the Turtle Mountain Band of Chippewa Indians in Belcourt, North Dakota. She completed both her Master's of Public Health and Community Health Education with a concentration in health disparities, and her PhD in Social Behavioral Epidemiology at the University of Minnesota School of Public Health. Dr. Mel is a community-engaged scholar and has worked for more than 19 years on various research and evaluation projects within the American Indian community. She has successfully engaged a multitude of tribal health stakeholders from across the nation and is dedicated to improving the health and well-being of Native communities. Dr. Mel currently serves on the Turtle Mountain Band of Chippewa Indians Research Review Board as a program co-chair for the American Evaluation Association, Indigenous Peoples and Evaluation Tropical Interest Group, on the American Public Health Association, American Indian, Alaska Native, Native Hawaiian Board, and co-chairs the Tribal Health Data Work Group for the North Dakota Department of Health. Dr. Mel also serves as interim chair, graduate program director, and assistant professor for the Indigenous Health PhD program at the University of North Dakota School of Medicine and Health Sciences. Welcome, Dr. Mel. Thank you.
Thank you. Thank you so much. Good morning. So let's see, make sure I'm doing this right. So today I'm going to be talking to you about taking a community-led and culturally grounded approach to supporting health and well-being of Indigenous youth, and really touching on the seventh generation principle. I wanted to acknowledge the land that we're on and feel very grateful to have been invited here, and want to honor the original peoples of the land. And so I thought I'd include the University of Washington land acknowledgement. So the University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. Disclosure, neither I or any member of my immediate family has a financial relationship or interest with any proprietary entity producing healthcare goods or services related to the content of the CME activity. My content will not include discussion reference of any commercial products or services I do not intend to discuss an unapproved investigative use of commercial product devices. So a little bit about me. I like to start here because this really tells the foundation of who I am and my positionality. This is a digital story that I created probably about 8 years ago now. And I was working with some public health professionals to really learn this method of digital storytelling, which is very effective and used in a lot of ways. And hopefully one day I'll be able to use this with the youth in my community as part of the intervention that the community selects to use. So the video really talks about like why I went into public health. Here's a picture of me in the 3rd grade. At this age, I started thinking about what I wanted to be when I grew up. This is a picture of my Uncle Benny, Dad, Mom, and Uncle James. My Uncle Benny died from an unintentional injury, my mom from cancer, and my dad lives with diabetes. Both of my grandparents passed away from cancer. My Uncle Baby and his daughter Ivy were shot and killed by the same bullet. My Uncle Edward passed away from cancer. Eventually, I would go on to college as a first-generation college student. Experiencing all of this loss motivated me to pursue a health career. My Uncle Bernard passed away from an aneurysm. My cousin, Bernard Jr., passed away from cancer. My stepfather passed away from an unknown cause. My Uncle Francis died of asphyxiation. Right before I graduated with my master's degree in public health, my father had a toe, partial foot, and a below-the-knee amputation due to his diabetes. I'm happy to report that it's been 4 years since his amputation. His first prosthetic leg says a lot about his personality. It has lightning bolts on it. The fall of 2010, I entered into the PhD in epidemiology program in social behavioral health. My father has since passed away with COVID, and then I've had a number of other family members that have passed away. When I was at the University of Minnesota School of Public Health, I was the only Native person in my doctoral program. And I'm actually the first Native person to have graduated from that program and the 5th in the nation to graduate from a school of accredited school of public health in epidemiology. And my classmates turn to me often when talking about Native peoples, and I would always tell them that, you know, my tribe is one of among 574 federally recognized tribes, and that it's really easy as an epidemiologist to get removed from the data. And of course, I'm talking to, primarily clinicians, and so you're on the other end of the spectrum. But my classmates, I'd say, when I talk about this stuff, I think about my family, I think about my friends, I think about my community, because it's really present. The disparities are ever present in our lives. So a little bit about me, a little bit more about me. I'm an Indigenous scholar. I'm a community-led scholar. I used to say I was community engaged, but now I say I'm community-led because my community makes all of my decisions. I go there with my toolbox and I present ideas, and then they make it their own. So it's a lot of fun. Background, as you know, I'm also a mixed methodologist, and I have also created a process for implementing Indigenous evaluation with Indigenous communities. So what we're going to talk about here is just one slide on the historical context of the opioid crisis. I'm going to provide you some recommendations from a national collaborative board that I sit on, another board that I sit on, and touch on what this collaborative board said in regards to the causes of opioid use disorder in tribal communities, as well as how to address it. Challenges faced by Indigenous youth, and then as time allows, we'll talk about some of the resources, but I wanted you to have the resources and highlight on the slides some of the things that stand out for me. So if we have time, we'll spin through those as well. And then conclusion, future direction, and call to action. So very briefly, pharmaceutical industry, the overprescription of opioids by the pharmaceutical industry led to widespread addiction in the United States. There's stigma and bias around this. Patients who suffer from substance use disorder are often stigmatized and underserved by medical professionals. And there's also cultural trauma. The historical trauma of marginalized communities can lead to distrust of medical systems and treatments. And a lot of folks that aren't familiar with the history of colonialization, with all the tribes and with the people that were involved in that process, it's a very diverse narrative. So I'll just leave it at that. Can go down a rabbit hole with that one. So recommendations from the collaborative board. So here we are, we're in Albuquerque, it's 2020, and they brought us together to have this really intense think session, give us the background of the research that they were doing, build our capacity around what they were focusing on, implementation science, and really pick our brains and gather our collective thoughts using a World Cafe method, which was adapted into a Res Cafe method. They called it Res Cafe, which was kind of fun. And it was 2 days, and it was really a really great experience. So when we were at that particular event, I told the researchers, I said, we should publish on this. And so we did. And so I, second author on this particular manuscript, but I'm the one who analyzed the information from those sessions, and that's what I'll be sharing with you. So this is funded very briefly. This is a CTN. There's 18 research nodes across the nation. This is one CTN that pulled us in and created this national collaborative board to inform their efforts. And so they used a CBPR process. They are working with urban reservation based. It's an implementation study to support the cultural centering of the delivery of medications for opioid use disorder. And the collaborative board was convened to identify key components of culturally centered implementation intervention, introduce a tailored implementation science strategies, and build partnership with academic research team for bidirectional learning in achieving the study aims. And they were very successful at it, so I'm still part of this initiative. And they're wrapping up their field work now, so I'm pretty excited to see what comes out of that. When they brought us there, they said that there was this California needs assessment of tribal MOUD, and shared some of the, from 2020, and shared some of the challenges and risk factors. There's some of those are treatment access, transportation, insurance coverage, unstable housing, privacy, wait lists, historical intergenerational trauma, boarding schools, loss of language, loss of land, cultural disconnection, economic stress, mental health comorbidities, polysubstance use. The protective factors, on the other hand, were cultural cohesion and activities, family unit dynamics, provider, consumer communication for non-native providers, education exposure, and integrated care, case management. And so you can see we had a very diverse group there. So we had physician describers, behavioral health providers, both native and non-native. We had native people that were knowledgeable in traditional healing practices and the worldview, as well as native adults with lived experience that were in recovery. There were native elders, native ethnobotanists, NIDA CTN representatives, dissemination and implementation experts, and native researchers. That would be me. So they adapted, like I said, the Res Cafe. It was a qualitative facilitation method. Roundtables were set up, and they were doing these mind maps, and there was 3 coders independently reviewing, and we were rotating tables. And as we were doing this, they had Matt at the center, and I'm like, well, if you're trying to center culture should be at the center. Culturally centered approaches. And so we did another mind map. So I kind of deviated, and then this is the comparison of those two mind maps and what came out of the conversations in general. So we were there to describe complex causes of OUD among Native communities, discuss Native cultural strengths, the integration of healing traditions, practices, and holistic approaches to wellness in MOUD, and examine the process of using mind maps to identify similarities and differences across treatment perspectives centering wellness versus MAT, and discuss the importance of providing culturally responsive services to Native communities. So causes of OUD in Native communities. So individual level stress, depression, loneliness, low self-esteem. So one collaborative board member stated stress, anxiety, probably mental disorders, having a mental health comorbidity could be a trigger. Other causes, history of adverse childhood experiences, historical and intergenerational trauma, and family cohesion, and traditional family practices were eroded by colonization, forced relocation of the people, other systematic forms of oppression. Trauma in general, lack of social support, stereotyping, drugs have been normalized as a coping behavior in some Native families. And when talking about stereotyping, medical professionals targeting and labeling Native people as addicts can be internalized, leading to more use with the individual that's using. The healthcare system, providers not delivering adequate information, providers not managing clients well, physical injuries leading to longer-term substance use disorders, prescribing opioids with a one-size-fits-all approach. So another member said, I think a lot of people get into it. They'll have an accident of some kind, they'll get a pain prescription, oftentimes a little bit excessive, or it extends too long. And then I think sometimes the provider realizes the pain should be minimum right now, and they either will just abruptly discontinue or not taper. Then people go through withdrawals, and a lot of times people will then either buy pills to try to manage their pain, or the withdrawals, and then they go through withdrawals and then turn to heroin. I think people are often set up for opioid use disorders. Opioids viewed as acceptable drug that is not harmful because they're prescribed by a medical professional, so not having that understanding of the risks of going there per se. The misunderstanding of dependence that can develop from opioids. Some people feel like it's a prescription, that it's safe, that if it's from a bottle, it's not going to become, you're not going to become dependent, you're not going to be as harmed as opposed to buying it on the street or from heroin. They'll take a bunch of pills not knowing that it could actually lead to overdose as well. So I think it goes back to that misunderstanding about the safety of the medication. So addressing OUD among tribal communities, it's important, this collaborative board said, it's important that we have a compassionate workforce, does not shame or stigmatize, maintains confidentiality and trust. The initial contact is crucial to bridging the gap between the individual and the provider, allowing walk-ins, flexible schedules, personalization of treatment goals, understanding of both short and long-term goals, and building rapport and collaboration. Learning from programs that are models of care, successful tribal treatment programs, medical home model, having a customized menu of options, providing medications on site. So then the first mind map, what we did was the strengths of the community. And you can see that they identified a ton of strengths. And so, I won't go through all that, but yeah, that was just to get us grounded in what were the strengths of our community in talking and addressing this issue. So in summary, family. Family came up a lot. Family support, clan systems at the individual level, men, women, two-spirit. Each individual plays a role. Leadership, it's said like everybody plays a role in leadership. Everybody is a leader in their own way. Family, community connectedness, spirituality, providing resources to their families and relatives, providing diverse knowledge to the next generation. So here's some more thoughts from the collaborative board. Family, like knowing about other family members that went through the same thing, or they survived a similar ordeal, whether it's addiction to drugs or else alcohol. From an individual's strength to the traditional strengths, spiritual strengths, family, clan, community, tribe, location, any kind of strengths that we can bring to help them in maybe the program aid better in recovery. More broadly, family, social, kind of community networking, religion, spirituality, language, cultural identity. So they also focused on the integration of healing traditions, practices, and holistic approaches to wellness when discussing MOUD. Cultural grounding, so engaging and re-engaging with culture. So because of the Relocation Act, which was really designed to get tribal people removed from their community out into the urban community, both of my parents went out on relocation from the reservation. And it was a one-way ticket, and oftentimes the things that they were promised weren't there at the other end. And so we're in the middle of North Dakota, right by the Canadian border, and people were sent to all the major cities. So you're talking like Chicago, they were sent to California, they were sent to Seattle. So all the major cities they were sent out to. And they had to find their way back if things didn't work out. So, and the services weren't there, but the people came together and they'd make soup and support one another, and very community-oriented people, and so they knew how to survive, and they survived and got through it. But you'll see that some people that happened with, they're in the urban community, but they're really having identity issues around being removed from their culture and from their community, and having the need to have that reestablished and re-engaged to support their health and wellness. Traditional healing practices, forgiveness, humility, nourishment of the native spirit, spirituality, one cultural connection point, importance of understanding drumming, songs, and talking circles. So integration of healing tradition practices and holistic approaches to the wellness in MOUD. So a spiritual foundation must first be built in order for the context of the treatment to be understood and accepted. It's another thought from a collaborative board member. Take the time, sit, talking circles, drink traditional teas, cedar water, discuss what is on someone's mind, reduce anxiety, promote healing, sweat lodges. When you're sitting in a lodge, I can't go into too much detail what it's about. It's almost like a form of meditation. There are songs, there are prayers, they have long talks. Importance of individuals defining what holistic healing means to them. How do they define that, and what does that look like, and how can we be supportive on their journey? Provide opportunities to practice traditional healing, celebrating treatment milestones. You'll see some institutions that are actually creating healing spaces for people to go in and pray and smudge and burn their medicines and just get in a good headspace. Providing opportunities for healing to the youth. Conceptualization of pain. Having a menu of options for holistic healing, space for traditional healing, consensus that Western-based medicines over-emphasize relieving pain, viewed as unsustainable. So another collaborative board member said, through this form of meditation and these long ceremonies, you are experiencing pain. You're facing that pain. Then you're facing it with people to support you. You're not going through this alone. So just this concept and this ideology of the ceremonial practices, there was some level of pain present with that spiritually, and just saying how those perceptions and those views have changed and how important it is to reconnect with culture and gain an understanding of how that was traditionally understood, because it drives your healing, knowing the way that your people viewed this traditionally. I think pain has been recognized as part of the human experience, and different cultures have different ways of experiencing and expressing that and addressing that. And in the client population that I see, some people feel like pain is something just to be endured with suffering, where others are kind of in this learned helplessness where everything needs a medication for it. So it's a wide, very diverse understanding and tolerance of pain. So people are at different places with this, and there's just a need. And I think regardless whether you're working at the clinical level or whether you're working at the community level, we really just need to be responsive in our approach. So, results of the mind map. So this is the mind map that they did, and I'm like, hey, why isn't holistic healing at the center here? You're culturally centering this. And so you can kind of see there's spirituality, and there's like three main arms, and then this arm, education, just kind of spawned out into different considerations. And then there's an arm for spirituality, there's an arm for culture. Well, once we centered holistic wellness, facilitates healing and fosters resilience, we can see that we get a completely different map. And so the narrative and the approach is completely different when you start with that. And so you can see that there's circular inclusion of elders' spiritual teachings, there's culture, there's a mental, emotional, physical, environmental, the need, really fleshing out the need and what the community's view of what is needed and honoring that, starting where they're at. And you'll see some communities are doing needs assessments to really gain a handle. Is that actually where they're at? Maybe not, but their perception of where they're at is going to impact the progress of dealing with this issue. So knowledge, awareness, and physical effects. So you get the idea. It just really looks totally different. The focus on the whole family, that came up a lot. And so here's a side-by-side. So implementation should use a strengths-based and holistic model of OUD recovery and well-being. Engagement, recovery strategies, integration of extended family traditions, addressing stigma, and building trust with providers and clients. Integration of traditional healing practices, ceremonies, and other cultural practices recommended. And then the importance of centering Native culture and involving the family. So dissemination and implementation. Remember I said they had those experts there? Well, this is what came out of those conversations. Native communities need culturally appropriate and effective substance use disorder treatments. So unfortunately, when we're looking at the evidence base, you always have to ask yourself, whose evidence is it? And social determinants of health are going to really determine how successful that evidence is. So are the social determinants of health that are impacting that particular population at least kind of similar? And that doesn't even bring in cultural considerations. So depending on what framework you're using, because my framework has culture, and culture is all encompassing, even includes policy and all the other levels of the social ecological model. And so when looking at this, they also mentioned the community-based participatory research and engaging with community members and considering community needs and context from development to implementation. Let culture guide the research and consider sustainability during intervention implementation. Identified frameworks, theories, models that align with community worldview and values. So unfortunately, Native people have not had the privilege of being able to have evidence-based investment in their communities from a community-grounded, informed approach to addressing the problems that are impacting their communities. It's always been bringing in and say, well, hey, works over here, with this population in an urban city. Why don't you apply this over here? Why don't you apply this over here on the reservation? And maybe it's not that extreme, but just for the purposes of demonstration, that you can imagine, it's like, that's probably not going to work here. So funders can pigeonhole, and it really limits our progress, not being open to being responsive and investing in the community, because the community knows what needs to be done. Identifying frameworks and theories and models that align with community worldview. So the Indigenous Health PhD program that I'm overseeing right now, we launched that 3 years ago. I'm the co-creator of it. It's the first Indigenous Health PhD program in the world. We created, me and Dr. Donald Warren, friend, colleague, he said, what would you think this would look like? And I said, well, and so we designed it to walk in two worlds. And so I say, this program is a program that allows individuals who are in academia, whether it's faculty, staff, or students, to walk in two worlds in academia. So we not only focus on the Western methods, because they're important and they're useful, we also focus on the Indigenous methods and theories and worldview. And we talk about where they intersect, where they overlap, and then where they diverge. And so they're not mutually exclusive, but there are key differences, and you have to think about that in your approach and application to doing this work. And we've been very successful with our 4 graduates. We just recently graduated our first 4 graduates, and we have 60 students that we've admitted to our program. And to date, we've only had one person that had to withdraw, for reasons beyond their control. So it's exciting to be part of such an initiative that can really start building the evidence base and scholarly works around frameworks, theories, community-informed interventions, and data collection methodologies. If we have time, I'll tell you about my other research that I do, but I got my fingers in a lot of pots. We can heal our communities through culture, culture, connection, and developing interventions and policies that are grounded in traditional Indigenous knowledge, tribal best practices, and evidence-based practice. Tribal Opioid Response National Strategic Agenda. So from this gathering, in summary, there's complex factors that lead to OUD. There's cultural strengths that promote wellness. There's holistic health options that support and support for pain. Centralizing holistic wellness compared to MOUD in the mind map resulted in different conceptualizations of the treatment. There's no way MAT is going to really work in Native communities in the long term unless we center it culturally. There's no way. There's just no way. Unless we incorporate ceremony and traditional medicine in the form of like plants or whatever is relevant to those communities, there's no way it's going to work for them. I mean that. That's my firm belief. So challenges faced by Indigenous youth, and these are not mutually exclusive, but I just kind of wanted to give them some space. So structural inequities, addressing the systematic barriers that contribute to substance use vulnerabilities, so poverty, limited access to healthcare, educational disparities. So you'll see that educational disparities exist across, high school, college, all levels. And then I say we have disparities upon disparities because when you break that down, much more of our women are educated than our men. So our men are really struggling and need a lot of support in all areas and for all outcomes. I'm currently working on a paper that will be coming out that looked at the average age of morbidity in North Dakota, and it's modeled after a paper that they did in South Dakota. And this is pre-COVID, and then after we get this published, we're going to do post-COVID to see how it changed. But what we're seeing is that the average age of death in North Dakota is 20 plus years younger for tribal peoples. And so when you think about that, and even when you think of stuff like retirement or access to benefits for like disability, or people aren't living that long. So then you're basically working until you die, so like the whole population. And so really being responsive to where people are at and advocating for policies that make sense. Intergenerational trauma, recognizing the lasting effects of historical trauma in Indigenous communities and the need for trauma-informed approaches that promote healing and resilience. Mental health and well-being, prioritizing mental health support, ensuring culturally responsive care that addresses the unique challenges and strengths of our Indigenous youth. And then developing effective strategies, collaboration, and partnerships, working together to create a comprehensive network of support. Indigenous communities, educational institutions, healthcare providers, government agencies, and et cetera. I'll say et cetera because there's more. So the resources. So this is, as time allows here, but it looks like we're doing good on time, huh? So this, I looked this up last night, literally. So I wanted to share it with you. Was anybody aware of this? They had a Washington State Tribal Opioid Fentanyl Summit this year. Anybody hear about that? We have one person. Did you attend? No. Okay. So Strengthening Pathways to Healing held May 2023, and this summary report overview of key findings and recommendations was released June 9th, 2023. The breakout sessions focused on justice, treatment, recovery, prevention, housing and homelessness, community, and family, and they identified key priorities. So I tried to pull those out for you. The justice breakout session, expanding access to diversion programs, detox, inpatient treatment, intensive outpatient treatment. Many places don't have detox. And we're even talking about alcohol. Someone in my family, my husband's family, my family, because that his family's my family, got stuck in the system because the treatment center wouldn't take him because he had something going on with his leg, and they're like, you have to have that resolved before you can come to treatment. And then the medical system wouldn't take him because he wasn't detoxed, and so he was stuck in the middle. And I detoxed him. I know that sounds crazy, but I did. I detoxed him, but he got away from me. He did. He's like, can I just go over here, And then he ended up getting away. He ended up passing away. But I used food to detox him. So I really looked at like what are the foods that detoxify our systems, and there's these movements out there that are really looking at food as medicine. And I just came from the Native American Nutrition Conference here about a month ago in Minneapolis, and it was amazing. They had Indigenous chefs from across Turtle Island, and it was phenomenal. And everybody was talking about it because the whole menu was pre-colonial foods, right? And so Sean Sherman, who is the sous chef and world-renowned now, if you ever go to Minneapolis, go eat there. Old Omni, it's amazing. But he only serves pre-colonial foods. Everybody's talking about how energized they felt. They weren't sleeping as long, how their mood was improved. And this was a collective conference. They're like, it's crazy. Like, I can't believe how much energy I have, because they provided all the meals. And I'm like, hey, they should study this. Because you could see, you could feel it, and people were just genuinely happy, and the food is really, really good. So I think that we have, and I hope to one day actually try this as a intervention to test it, to see if we can make advances dealing with this issue using food as medicine. So increasing coordination with tribal diversion wellness courts, supporting tribal drug task force, addressing missing and murdered Indigenous persons issues, strengthening traditional judges and cultural practices, improving detox program, including tribal representatives on jail standards task force, addressing legislative veto, enhancing collaboration between tribal police and other law enforcement agencies, raising awareness about the dangers of fentanyl among the youth, continuing the state-tribal collaboration, declaring a public health emergency. Long-term priorities, integrating culture into treatment programs, empowering tribes with independent funding decision-making, improving the accessibility and capacity of treatment services. Long-term priorities, funding future opportunities that require regulatory, legislative, or programmatic efforts, so these take more work and more investment. Advocating for adjustments to the methadone loading dose, given the potency of fentanyl. Advocating for adjustments to the methadone loading, given the potency of fentanyl. Focusing on youth-oriented programming, expanding residential care infrastructure for families of individuals in active treatment recovery programs. Housing and homelessness, lack of affordable and accessible housing, need for increased access to housing with medically assisted treatment met. And so you'll see, unfortunately, even though Native people represent the smallest population in the United States, we represent the highest population among the homeless. And this is like across the nation, and that feeds back into those policy decisions that were made in the past. People go out cities, they end up homeless. And it's a lot more complex than that, but colonization and the political decisions that were made directly drove what we're seeing today. And we all know that policy impacts what we see, but so other support, including wraparound services, transportation, childcare, workforce development, counseling programs, addiction treatment, mental health counseling, culturally appropriate care, access to lower barrier or harm reduction housing solutions, funding, housing solutions. So the Mandan Hidatsa Rikara, and I wanted to go tour the center. I'm planning on doing it. I just haven't had the time. But they have a program that they've invested in North Dakota, and it's really successful. And so they have a male facility and a female facility, but they let them stay there for a good amount of time, but then they also get them re-engaged to build their capacity for education and getting them functioning in the community again, and it's working. So there's successful models out there that we can look to when working at that level. Funding should be provided directly to the tribes with discretion to decide how to allocate resources. So instead of this blanket approach of saying, okay, we're going to open up this funding opportunity that's limited in this way to all the tribes in the United States, it's kind of silly when you actually think about it. It's like, can we be more responsive in our approach? Community and family session. So here's what came out. Educate the community of the epidemic at the same level as COVID-19. That was pretty impactful when I read that. I was like, wow, that's really a powerful way of looking at that. Strategies to improve communication between state and tribal entities, explore and enhance interstate compacts for treatment, need for declaration of public health law emergency. Permanent authorization for telemedicine, build capacity for providers and law enforcement officers, assessment of laws to strengthen and loosen where applicable, so having that flexibility to adjust the law so that they're not so written in stone. Licensure streamlining. Focused efforts that require more time. Programs that provide a continuum of care for those struggling with addiction, increasing the focus on prevention through low or no barrier activities for children, partnering to address issues like trauma and homelessness, strengthening family units. So I'll touch a little bit on my research, but you can read about me at www.und.edu and just search for me in the directory. And I put everything on there. My CV, it's all hyperlinked. I even have a table of contents for my CV. I'm really proud of that. Yeah, it's cool. So you can navigate through my stuff pretty easy. I have, in the media, I have my interviews on there. I have my digital stories. I have another digital story that I did, so you can check that out. That one's more on my educational pathway. But anyway, so, just to tell more of a story here for a minute. So when I was in school, I almost dropped out of the doctoral program because I was going to go home for the summer. And I was about 7.5 hours if you drove straight through without stopping from my community. And I went there on a Bush Foundation, and so I had, financial support that I had been awarded. And I did my master's in public health, and then when I was working on my doctorate, the first summer that came along, my advisor said, because I was telling her I'm going home for the summer, and because I used to go work at IHS as a student extern every summer, because it paid pretty good, and then I worked in all the departments. They all knew me there. It was a lot of fun as a student just seeing how things operated. And so I said, I'm going home for the summer. And then my advisor said, you can't go home for the summer. Doctoral students don't do that. You're expected to stay here and do research for whatever until you graduate. And I'm like, I'm probably going to have to drop out then because that doesn't work for me. And she didn't just say like, okay, well, that's your decision. She said, let me think about this. Because I had already worked with her through my master's and we were very close and she was very supportive. And she actually ran the American Indian Community Tobacco Projects, another project I worked on, in the cities. So then she came back and her team actually wrote a training grant and she picked my brain. She's like, why is community engagement important? Why is it important for you to go home every summer? And she wrote a T32, I think it is, for a training grant to train community engaged scholars. And I was the first awardee on that, And so it was amazing. And so like I realized, through my experiences, I realized, because at first I was working on culturally adapting a data collection tool. And then I'm like, why aren't we creating our own tools? How can we do this? How do we validate it? So now I'm actually working with my community to build a data collection tool. They're informing, it's totally community informed. And so I just finished collecting data from, I have 48 recordings. It's just a lot. But I have youth and then adults who work with youth. And I have focus groups with cultural knowledge keepers, behavioral health specialists, and school administrators. And so now I'm going to take that, write a community report, provide some recommendations, but then use that to create the tool. Because YRBS, it's a great tool for national representation, but we're the smallest population in the United States, but we are also the most diverse population in the United States. And so that approach doesn't work for us. And we fall through the cracks. And there's only currently 2 tribes that are represented in the youth behavioral risk surveillance system. Really quickly, like in my community, they administer it in school. Well, we have about a 30% dropout rate. If this is a risk survey, we're not even getting the highest risk students. So our data's crap, So I'm trying to change that. So you can read about it, publication. I have a publication out on it. And what I did was I said, okay, we know from the YRBS research, we know that substance use leads to cancer. We know that diet, nutrition, physical activity related indicators impact cancer over the lifespan when you're looking at the youth. These are lifelong trajectories that we already know. And we know that sexual health impacts cancer over the lifespan. What we don't know is what is the risk and protective factor profile of Native youth for substance use? What is the risk and protective factor profile for diet, nutrition, and physical activity related indicators? And what is the risk and protective factor profile for sexual health? And so that's what I'm trying to figure out for my community, Turtle Mountain Band of Chippewa Indians. And so I published on this. It's the first review of its kind. I seen that protective factors span multiple levels of the social ecological model. Findings could guide strengths-based health promotion, prevention, research. Key cancer-related indicator with the presence associated. So substance use, this was like the strongest finding, like with all things considered, looking at all of these indicators, right? So substance use, and this was a mixed methods literature review that I did. I went all the way back, looked at everything that had been done, and then I stratified it using the social ecological model. And then I added culture on the outer realm. So substance use, key cancer-related indicator with the presence of associated risk and protective factor at all levels of the SEM. So individual, interpersonal, community, family, policy level, cultural level. It was across. And I looked at significant and salient findings for both quantitative and qualitative data. So efforts to reduce substance use-related risk and protective factor profiles should be aimed across the SEM. Substance use was also a risk factor for sexual health indicators, physical health diet indicators, and both individual levels. So use this information to guide prevention efforts, data collection, translation, build capacity, promoting connection and belonging. And let me do this time check. What do you think?
You have 10 minutes.
Oh, do I? Okay, cool. I'll finish right on time then. So ensure effectiveness, ensure sustainability, recognize the power of traditions, encourage artistic expression, just the engagement of artists in the work that we do. And so artists are theoretical worldview knowledge keepers, is what I would say. And so it's very important that they're included and supported in the work that we do. And artistic expression is also used as a form of healing with the youth as well. Honor the wisdom of the elders. So strengths-based approach, engage youth as leaders, active participation, have the youth put in a decision-making role, promoting ownership and agency and creating positive change. And then community interventions really need the involvement of the youth, elders, and community members, because this is a community issue. It needs a community approach. So now I wanted to share this resource. I love this resource. I just found it a couple weeks ago and I'm like, this resource is amazing. It has the historical overview of the political impacts to Native people. So it goes over every policy and it has a really nice charts, a few pages of every policy that was targeted specifically towards Native people. That directly impacts what we're seeing today. So if you want to spend, of course I don't have time to talk about that today, but this resource is an excellent resource for that. It also shows where the evidence base is at in regards to substance use. And so it's 200 pages. And this is intended, supported by SAMHSA, intended for providers. Excellent resource. So I'm just going to mention some things here. So community-based behavioral health programs. So they kind of went over what's out there, and I'm just trying to summarize it very quickly. Talking circles, educational groups, youth gatherings, drum-assisted recovery, outdoor adventure, cultural heritage days. Those have all been successful in addressing substance use. Culturally adapted treatment approaches, so taking a treatment approach, adapting it for use. Family therapy, trauma-informed treatment, community reinforcement approach, mindfulness-based interventions, cognitive behavioral therapy, matrix model behavioral therapy. Evidence-based tribal practices, longevity, teachings, values, principles, elders, community. Current community practices and programs, community prevention and education, cultural and subsistence skill development, early intervention skill building, individual and family treatment, recovery services and supports. So now we'll talk conclusion and future directions. But you see how all of these things I'm talking about, my work, what happened in Washington, what this national resource for providers, there's themes. You can just see, so even looking at this from like a triangulation view of like, what are we seeing? It's obvious if you kind of look across what's coming out of these various silos. So I wanted to touch on and kind of finish with this. I got probably 5 slides left. The 7th generation principle. So cultural wisdom, emphasizing the responsibility that we have to consider the impact of our actions on the future generations, empowering them by bringing together traditional values and modern approaches. Long-term vision, guiding us to make decisions that prioritize the well-being of Indigenous youth today, ensuring a positive legacy for generations to come. Holistic approach, recognizing that positive change can only be achieved through comprehensive strategies that address the social, cultural, and emotional dimensions of substance use prevention and support. So, in conclusion, culturally aware, sensitive workforce, safe workforce, providing ongoing training and for healthcare professionals to better understand the cultural, economic, and social factors affecting patient care. When we were doing a pilot study in my community around MOUD, that was a big thing with the providers. They weren't supported. If they did this kind of thing, they had to do it on their own time, and they don't have time. So we need systems change here to support this professional development. Cultural and health literacy, improving cultural knowledge and communication skills among healthcare practitioners can help patients better understand their treatment options. Multidisciplinary teams, collaborating with interpreters, social workers, public health professionals, and other healthcare professionals to ensure the highest quality of care. Community outreach, working with community organizations and leaders to build trust and improve access to care. So, cultural knowledge in medicine is critical to addressing the opioid crisis and improving outcomes for all patients. Moving forward, we must continue to prioritize culturally sensitive and safe care and develop innovative strategies for reaching diverse populations. Conclusion and call to action. Together, let's honor the 7th generation principle and empower Indigenous youth to navigate the challenges of substance use. By embracing a community-led and culturally grounded approach, we can create a resilient and thriving future for generations to come. Thank you.
You did it. Thank you so much. We have 5 minutes left, about 5 minutes left if anybody in the room has questions. And also, if you're on WebEx, you can type your question and I will ask it on your behalf. Did I see a hand? No. I do. Sometimes I am mad.
Thank you so much. That was absolutely, I learned so much just in 55 minutes.
I tried really hard.
I know, it was great. Whoa. So one of the questions I have is, how do you get the youth to, because do the youth really want to do sweat lodges and do all the things that are traditionally part of who they are? Is that just a no-brainer, or how do you, is that in the Native kids, is that what happens?
So, of course, I'll say it, I have to say it again. I can talk my experience from my tribal perspective, but there are, 574 federally recognized tribes, state recognized tribes, and then, of course, those who are fighting for recognition, and then, of course, those who were completely annihilated. But for my community, what we're finding from the qualitative phase of my study is that they want to be re-engaged with their culture, but we're having the church was sent in, because of the boarding school era, and a lot of dysfunctional things happened in a bad way. And so it's really complex, but in my community, we're kind of seeing this. I mean, this is the youth voice, the youth voice saying, oh, the people that are really into church are at odds with the people that are really into culture, and they're really distressed seeing that divide. And it's like, can we agree to disagree kind of thing, and like work together and understand what has happened to our community and work towards healing, and regardless of the ways that we want to practice health and well-being, can we be supported and can we be provided a space for that? So adults in my community, from their perspective, they're like, yes, there are opportunities, and there probably are opportunities, but do the people that want those opportunities have access? And oftentimes they don't. They either don't hear about it, they don't have a ride, they don't have money, they're stigmatized, they feel like they don't belong, there's mental health barriers, issues that are going on. So there's not one answer, but it's a really great question. And I would say yes, there are youth that need that space, and we need to cultivate, like I said earlier in the presentation, provide space for engagement with culture, re-engagement, because there were a lot of families that were torn from their culture, and it was outlawed. I was listening to a book last night, my audio book, because University of North Dakota does these amazing book clubs, and they're having David Truer come in, and he's a famous author. And so the book club that we're having right now is on his book, and he's going to be doing a keynote on that particular book. But it's basically a historical overview of colonialization in America. And one tribe, and I'm learning, I'm like, wow, I didn't know that colonization was so diverse. Like, what happened to people, their narrative is so different. It's so, depending on if it was, the Spaniards, English, the French, like it's just a different narrative. They all, Jesuits, like they all handled and, worked with Native people in different ways, and it's a different history all across America. So the narrative is very diverse, but there was one tribe that was completely wiped out, and it was illegal to even say their name. And I was like, wow. So just listening to this historical snapshot of what happened, it's really eye-opening. And so we have to, I think Dr. Donald Warren said it the best, in order to start our health and healing, we got to start from a place of truth. So.
Thank you, Dr. Mel, so much for giving the grand rounds today. And we have to wrap up. We're on time. But thank you all for being here, and thank you to everyone online. One more round of applause.
Thank